and welcome and thank you all for joining us today. I am Caitlin Mitchell, and I have the privilege of managing the WHO-UNFPA Learning by Sharing portal. Before we begin, I'd like to go over some general housekeeping. Next slide, please. Thank you. First, we will be, as I mentioned, providing Arabic, French, and Spanish interpretation. To utilize the interpretation feature, please read and follow the instructions on the interpretation slide that you see. We will also be recording today's webinar. You can access this recording on the WHO HRP YouTube channel. I would first like to start off with acknowledging that we are all living in and through very difficult times. I hope that you're all taking care of yourselves as best as you can. I know that I myself have also been feeling quite hopeless, but I know that we must remain steadfast in these times. And I'm actually reminded of one of my favorite quotes, which is, "Where flowers bloom, so does hope." And I hope that you are all able to see a few flowers during this time. Today, the WHO UNFPA Learning by Sharing portal, the LSP for short, will be in partnership with WHO Pakistan, WHO or the WHO sub-office in Punjab, and the government of Punjab, hosting an event to commemorate World Health Day, which was celebrated across the globe on Monday. This year's theme, Healthy Beginnings, Hopeful Futures, urges governments and the health community to ramp up efforts to end preventable maternal and newborn deaths and to prioritize women's long-term health and well-being. On Monday, the latest maternal mortality estimates were released, and the numbers are startling. These new estimates tell us that 260,000 women will lose their life due to pregnancy or childbirth each year. And in fact, in 2023 alone, over 700 women died from preventable causes related to pregnancy and childbirth every single day. That's around one maternal death every 2 minutes. Meanwhile, over 2 million babies die in their first month of life, and around 2 million more are stillborn. That's roughly one preventable death every 7 seconds. Based on current trends, a staggering 4 out of 5 countries are off track to meet targets for improving maternal mortality by 2030, and 1 in 3 countries will fail to meet targets for reducing newborn deaths as well. And yet we also see progress. Between 2000 and 2023, the maternal mortality ratio dropped by approximately 40% worldwide. At the same time, Southern Asia achieved one of the greatest overall reductions in maternal mortality ratio, with a decline of 71%. Still, we must do more, and this task will not be easy, especially given the immense and ongoing reductions in funding for global health. Now, more than ever, it's important that we learn from one another and that we share strategies that can be adapted to other contexts. And we will be doing just that today. This webinar will explore an integrated rural ambulance transport service and communication system that transfers pregnant women and sick children from their homes in rural Punjab to health facilities for safe delivery and care. This story was originally featured on the portal as an implementation story in 2024, and the webinar aims to share country experience from Pakistan on the implementation of a cost-effective solution with a significant and measurable impact. We will also be taking questions from all of you, our attendees. Without further ado, I would like to pass it over to Dr. Yahya Golzar, a technical officer at the WHO sub-office in Punjab, to provide an overview of maternal mortality in South Asia and Pakistan. Thank you all, and over to you, Dr. Yahya.
Thank you, Caitlin.
And
I hope
next
I'm
slide.
audible. And yeah, thank you for giving the overview, but I will go a bit in detail. In Southeast Asia, the maternal mortality ratio has seen substantial improvement over past 2 decades, but the region still faces challenges. For instance, in 2020, the MMR in South Asia was 138 per 100,000 live births, with countries like India and Bangladesh showing notable progress. Central and South Asia accounted for nearly 17% of the global maternal deaths in 2023. This underscores the need for continued effort to enhance maternal health services and address socioeconomic determinants of health. Likewise, as Pakistan falls in the Eastern Mediterranean bloc, This region strides have been made in reducing the maternal mortality. The latest data indicate that while some countries have achieved lower MMR, other countries continue to face significant challenges due to conflict and institutional fragility. Coming to Pakistan, specifically, has shown progress but still faces considerable challenges. The maternal mortality ratio in Pakistan has decreased from 276 deaths per 100,000 live births in 2006 to 186 deaths per 100,000 live births in 2020, whereas currently it is 155 deaths per 100,000 live births in 2024. The progress is a testament to the dedicated efforts of healthcare professionals, policymakers, and community workers. However, the journey is far from over. The current MMR still falls short of the Sustainable Development Goal target of fewer than 70 maternal deaths per 100,000 live births by 2030. In Punjab, the maternal mortality ratio remains a significant concern with some fluctuation observed since 2020. Despite efforts to improve the maternal healthcare services, the MMR is estimated to be 157 per 100,000 live births, which is lower than the national figures of 186 per 100,000 live births. This indicates that while Punjab has made significant progress, there is still a considerable gap bridge to meet the SDG targets of reducing the global maternal mortality ratio. Likewise, as an overview of Pakistan, if you look at it, still other provinces contribute to the higher maternal mortality. Since 2024, per 100,000 live births, Khyber Pakhtunkhwa with 165 per 100,000 live births, and Balochistan contributing to 298 per 100,000 live births. Likewise, Gilgit-Baltistan is contributing to 157 per 100,000 live births. So I hope this gives a clear overview of the situation in Pakistan and Punjab context. Thank you.
Yes, indeed it does. Thank you, Dr. Yahya, for such a comprehensive overview of the maternal mortality in South Asia and Pakistan. And yes, this information is key, not only as we proceed to learn more about the rural ambulance service, but also as we learn what's at stake without this crucial service. So thank you very much for that. Next, I would like to introduce, just to confirm that we have Dr. Shazad here, I believe, that will be presenting on our, the program director for the Integrated Reproductive, Maternal, Newborn Child Health and Nutrition Program within the government of Punjab, and he will be presenting on the rural ambulance service. So welcome, Dr. Shazad.
Thank you very much. Okay. Let me introduce myself as you have already said. My name is Dr. Mohammad Shahzad Sarwar. I am working as Additional Director Operations at IRMNCH and Nutrition Program, Punjab. And today I am representing Dr. Khalid, who is Director IRMNCH Nutrition Program. Due to some important engagement, he could not make it here. So I'll be representing him and the department here. Let's start with the rural ambulance service, which was a very good service, and we are proud of it to start. Let's see the slides to understand it better. The rural ambulance service was launched in 2017 to save lives of mothers and children, as to address the second delay, as we could see it in the later slides coming. In the rural areas, normally there are ambulances for an emergency in every country, but as Dr. Yahya already explained, that to further reduce the maternal mortality and to address the challenges which are preventable, we started with the collective wisdom that how to approach and how to save lives, which are only subject to the delay in reaching the health facility, where they can prevent the preventable causes. So this ambulance was started in 2017 at a smaller scale, with many standard operating procedures and TORs and many things to consider. And given the also budgetary challenges we had, we started it in a small bits and pieces and gradually expanded it to now we have a 600. Sorry. Okay, next slide. So we now have 600, almost 600 plus ambulances working as a rural ambulance service, dedicated and specific to the shifting of the clients from rural areas, pick and drop services from home to the nearby health facility, and from health facility after the delivery. Given a period of time, staying there for at least 10 hours for the any observation or any complication, and then drop back at night back to the health facility. Additionally, over the period of time, we also added its scope that there are other issues which are somehow attached or we usually see during over the period of time. We observe that neonatal mortality and morbidity are also incorporated into that by increasing its scope, not only picking the pregnant clients, but also shifting it to the higher facility in the form of when we face any complication in the form of BPH or any other difficulty. Okay. So can you hear me clearly?
Much
Okay.
better. Yes. Thank you very much.
Okay. So in July 2017, we had this much of the coverage. You can see on the map, on the heat map of this is the map of Punjab. And later in November 2017, we also increased it, further expanded in its number. Then in 2018, we kept on adding into the number of ambulances by increasing and extending the coverage. And now in 2025, we have covered the whole Punjab. And this is within almost 30 minutes. The driver can reach from once the call is landed. It is another way. It's connected to a central response call response center, which is operated by a renowned company, and there are many standard operating procedures. Once the call is landed, that is relayed to the nearby driver, and which is connected by a GPS GPS map and satellite tracking. They can track it where is the nearby driver and where is that ambulance is parked. So from there, the call is landed to the nearby ambulance, and that ambulance immediately goes to pick up that client from home or from a health facility in case of shifting to a higher facility. This is how we address the second delay over the period of time. Initially, it was now 193 ambulances over 700 PHUs. Then it increased to 220 ambulances, which covered 803 PHUs, and then 483 ambulances, which covered 1,000 PHUs, and now it is 590 ambulances covering 1985 PHUs out of 2,500 in total in Punjab. We are also next slide, please. We have okay. So you can see from this slide, which is self-explanatory, that since then over 3 million mothers have used the service to safely deliver at public health facilities. Mothers transferred for delivery, which were normal without complicated, and mothers transferred for complicated deliveries, you can see the number over on your screen. On an average, we perform 700, on an average, 700 1700 tasks are conducted each day. Uh, Mainly, we segregate it into many parts to track its efficiency by the green tasks and yellow tasks and red tasks. So red tasks are very less, which are due to some malfunctioning on the part of the ambulance operations, and yellow tasks are those tasks which are refused by the client somehow. The ambulance is there, but the client was not there, or the client was already shifted or went. And later is the green tasks, which are already the patients which are shifted, who or the service is utilized. Next slide, please. Okay. Now the setup is already there. These are working continuously. Now our way forward, or looking forward, that how we can sustain it and further enhance its services. That is the replacement of old ambulances with the new ones, which has already been incepted in its concept, that once it is it has spent a time period of 3 years, I think, or the 300,000 kilometers. So we will replace it with the new one, and the possibility of having trained SPA in the cabin on the way, emergency delivery or ANC, antenatal, postnatal care, or child referral. So we can add a skilled birth attendant in the cabin, which is not there already. We are planning to add these SPAs into or on board on these in these cabin or in these ambulances. The other one is the to develop the app, an application to generate ambulance tasks for the patient pickup, referral, uh, like Uber or any other renowned apps, which can be developed so that they can approach not only by the call, but also with the use of app, as everybody has a ready access to the internet these days. And also is the projection, categorization for ambulance utilization in delivery and child referral in near future. Um, to this point, I would like Dr. Naeem also to add, because he has already been one of the pioneers when it was being developed. So we are looking to further project it and further enhance. Looking forward to see how it can be better utilized or be replicated in other parts as well.
Thank you. Thank you
Okay.
very much. Yes. Thank you very much, Dr. Shazad, for such an inspiring presentation on this outsourced transportation model. And yes, I believe you did a great job on laying the foundation for our next segment of the webinar. Next, we will debut a short 8-minute film, which actually features Dr. Naeem Majid, the Chief Executive of Sphere Consulting in Pakistan. Dr. Naeem is one of the original authors of the LSP implementation story, the Rural Ambulance Service, a public-private transport solution for pregnant women in Punjab, Pakistan. This video is part of the LSP video telling series, a visual storytelling series that brings our LSP stories to life. We hope that you enjoy the video, and this will be stored on the LSP for future watching. We can go ahead and play that.
My name is Dr. Naeem Majid, and I am a public health specialist in the Rural Ambulance Service Project. I was the lead person who designed and implemented this intervention from the platform of integrated RMNCH and nutrition program of Punjab province of Pakistan. About 15 years ago, in the Punjab province of Pakistan, we did not have round-the-clock obstetric services for normal delivery of women in the rural areas. And at that time, the government of Punjab initiated a new program whereby they made the primary care centers functional around the clock for obstetric care, the basic obstetric care, where normal delivery would happen and initial care of the newborn would happen. And by the year 2007, around 700 such centers were working across the Punjab province. But there was no means of transport for the women to reach those health facilities. So usually women would have to make their own transport arrangements. For example, hiring a rickshaw or a tuk-tuk. And sometimes they would hire a taxi. Sometimes they would even use a donkey cart or even maybe travel on a motorbike. So it was quite challenging for women, especially in the late hours at midnight, when usually the deliveries happen, to reach the end facilities. They were still reaching, but it was quite terrible for them. It was very difficult for them. So at that time, the government thought of providing them a transport solution. In 2016, the government of Punjab initiated the procurement of these ambulances. They procured some small vehicles and they were converted into ambulances to transport the women. And then in 2017, this rural ambulance program was launched. And this program includes picking up the woman from her doorstep at the time of delivery, taking her to the primary care facility. And then if there is a need for further referral, the same ambulance would carry the woman to a secondary or a tertiary care hospital. Before 2017, the government had another ambulance program by the name of Punjab Emergency Services, or the Rescue 1122, as it is very commonly known. So that ambulance service was at that time limited to urban areas, one thing, and the other, they were more focused on emergencies. For example, road traffic accidents, cardiac arrest, and other similar, like heart attack and any other emergencies which were health related, not the normal labor or a woman who would need the ambulance for a non-emergency. It is an emergency, but they would not consider it an emergency. There were two issues. One was that the service was not available in rural areas. And secondly, even if it was available, they would not provide services for such transport. Because the ambulance services were not available at that time, so women had to arrange on their own. So sometimes they would arrange a rented vehicle or a motorbike or whatever, or maybe they would decide not to go because, like, if at 2 a.m. in the night they need an ambulance, they need to go to the health facility for a delivery, they would obviously not go because they won't have any transport to go there. And secondly, even if they would arrange some transport, they would have to pay for it. So sometimes they won't have the funds or the money to arrange their transport. So even then they would decide not to go. Sometimes even a complicated pregnancy would happen and there is massive bleeding, for example, like postpartum hemorrhage, or there is an obstructed labor. And the woman would be stuck and she would not be able to arrange the transport and the health facility or the healthcare provider who is available with her at that time. They won't also be able to arrange the transport. So many of these women would ultimately end up into mortalities, or if not mortality, at least a morbidity, and that the child's health would be damaged or the mother's health would be compromised. Another important aspect of this rural ambulance service was that it was an outsourced service. It was managed through a third party. Previously, the government ambulance service would be run by the government itself, and there would be major issues of vehicle maintenance, the availability of fuel, availability of driver. In this program, the rural ambulance service, we decided to outsource these operations of the vehicles to a third party. So the third party would be responsible for provision of fuel, driver, and a ready to drive vehicle round the clock. So this was a very successful model because the government had been struggling to run an ambulance program on their own, but it was never a success until it was outsourced. So this the model was operated through different third parties, like the operations of the vehicle. They were run by a vehicle rental company, and then there was a call center. So the call center was centralized. It still is a centralized call center, which is located in Lahore, the capital of Punjab province, and it has a dedicated helpline, which is a toll free number of 1034. So women from across the Punjab can call this helpline, and a nearby ambulance is assigned to them based upon their geographic location. This call center has a functions around the clock, and they have a real-time dashboard in which they can see the actual positions of the vehicles as well as the locations of the callers. So they would coordinate and assign the nearby ambulance. So one cellular company was running the operations of the call center, while the operations of the vehicle are being run by a vehicle rental company. And the government is basically just managing the contracts and providing them guidance on what services they need to provide, how they need to provide, and paying them for the services. But the services are provided by the third parties. So this system has been really impactful. And when it was started in 2017, we had around 220 ambulances. Then around 250 more were added in 2018, 2019. So we had a pool of 480 ambulances by the start of 2020. And then there was a shift of the government as well. And since this was an outsourced project, so there were a lot of concerns and apprehensions about why a third party is running a government's vehicle and why the government is paying them a huge amount every year. So there was a lot of scrutiny as well of this project. And ultimately, they found that it is really cost effective. And the government decided to continue it and sustain it from their own budget. And now it is regularized. Since 2021, the funds for this ambulance service are coming from the regular budget of Government of Punjab. And the project is running so successfully that since the inception till today, they have transferred over 3 million pregnant women from their household to the primary care level or to the secondary level. And out of these 3 million, at least 500,000 women are those who are transferred from primary to secondary level or to tertiary level. And this means that out of these 500,000, these were the high-risk cases who, if there was no ambulance service, may have died or ended up in a severe morbidity. This program, I feel they have empowered the women because the women, they can now call the helpline from their own home, from their telephone, mobile phones, and the ambulance reaches their doorstep. So they don't need any male caretaker to be present all the time with them to go transport. So even if the males are busy doing their work out in the fields or on their jobs, so even then the woman can go with, the pregnant woman and her sister or her mother or her mother-in-law. They can accompany, and only the woman they can go. Otherwise, before this ambulance service, there at least one male attendant would be needed to go accompany them, at least to reach the health facility, and then he could go back. This has empowered the women and also enabled them to access quality health services at a government health facility. Yeah, despite all these successes that I have mentioned, obviously every program has its own challenges and difficulties, and this one also has. One of the challenge which we have started realizing now is that the drivers of these vehicles, they are males. And he is the only male person, while the women and the people accompanying her, they are usually women. So sometimes I feel that there might be some women who would be reluctant to use this ambulance because the driver is an unknown male, not from their family, and she's pregnant and in a vulnerable state. So she might not be very comfortable. So for this challenge, the government is thinking now of trying deploy some female drivers as well to see how it works, and if it is successful, maybe one day they would have all female drivers in all the 600 ambulances which are on ground today. The other challenge which I feel is that the women, they sometimes at midnight or at late night, they are going to the health facility. So the attendants, what they have with them in the vehicle, they are not medical people. They are usually relatives or some community health workers, which are known as JD health workers in Pakistan. So they accompany them. They are not very well trained to handle the emergencies. So maybe there is some sudden bleeding, or even sometimes the delivery may start while on their own route. This would be a challenging situation for the women, and this is something which the government is also again thinking of deploying maybe some trained healthcare providers who would be present throughout the journey, so that if there is any emergency during the travel, so it can be handled. My key takeaway from this whole implementation experience of the rural ambulance services, there are three different things. One is that the outsourced model is, I believe, very successful, and the government should preferably outsource the thing which they are not very skilled to do. Because, for example, the running of vehicles by a health department, which has an expertise in health but not an expertise in running the vehicles. So it is something which they outsource, and it was managed very successfully and very cost effectively. And secondly, I think there was a lot of use of technology in this whole project, like they were tracking the vehicles, tracking the patients, whether they reach the health facility or not, when they received, how much time was spent during the travel, how much time the driver took from receiving the call to reaching the home. These are the things which were very closely monitored and tracked through digital solutions. And I think that was a reason for success of this program. And I think all the community programs should use digital technologies as much as possible. I feel really proud that I was among the core team that designed this project, and there was a lot of flexibility provided to me by my supervisors and seniors, and they allowed me to pilot and test out whatever I thought would be beneficial for the general public. I feel really proud today that when we started, there were just 220 ambulances and just 1 or 2 calls per ambulance per day. And today there are 600 ambulances funded by the government and running round the clock and providing amazing services.
Thank you. Wow, what an incredible illustration. I hope that you all enjoyed the film as much as I did. Really amazing to hear about the evolution of a system that has transferred over 3 million women and 10,000 sick children for care. And thank you, Dr. Naeem, for bringing this story to life. Next, I would like to introduce Dr. Kutsia Uzma. Dr. Kutsia is a technical officer for reproductive, maternal, newborn, child, and adolescent health with the WHO Pakistan Country Office. She is also the focal point for healthy aging, women, and childhood cancers. Dr. Kutsia will be moderating our Q&A with the project implementers, including Dr. Sakani, Dr. Saeeda Khan, a lady health worker in Ali Raza Abad, Lahore, Ms. Kinza Fasal, a beneficiary from Alama Iqbal Town in Lahore, and Mr. Bilal Ahmad, a district transport officer in Lahore. Dr. Kutsia, I look forward to this engaging Q&A. We will now take questions from our attendees. Please, during this time, feel free to use the Q&A or the chat box. Thanks for being here today, Dr. Kutsia. Over to you.
Thank you so much, Caitlin, and assalamu alaikum to everyone on the webinar. It's really exciting to be part of this today's event and to learn about this incredible story on the rural ambulance service, which has, as we just learned, which has evolved tremendously over time and to the perfection almost. And it is indeed an excellent solution to a very long-standing gap in the healthcare service delivery system in the country, in terms of addressing the second delay and also serving the mothers and children. So as already explained by Caitlin, we have a galaxy of panelists with us who are all the heroes of this excellent experience that the country has to showcase today. So we have a list of questions already displayed on the screen, which has been gathered from the audience of the event. So I'll start with the first question that is being posed to our lady health worker, Ms. Saida. So the question is that I understand that women register for the service at their first antenatal visit. What does registering for the rural ambulance entail? So if you can kindly, based on your experience, share how it works. Over to you, Saida.
I will be interpreting for them.
Sure.
सवाल पूछ रहे हैं कि जब कोई खातून आती हैं एंटीनेटल विजिट के लिए तो उस वक्त आप उनको किस तरह से रजिस्टर कर रहे होते हैं सिस्टम के अंदर, ठीक है ना? हाँ, हेल्थ और फिर उसमें किस तरह से आप इनको लिंक करते हैं एम्बुलेंस सर्विसेज के साथ, ठीक है ना? तो आप उर्दू में बताएंगे, फिर हम उसको इंग्लिश में ट्रांसलेट।
अस्सलाम वालेकुम, मेरा नाम रज़िया आबिद है, ठीक है। मैं पीर मंसूरे से लेडी हेल्थ वर्कर। जब कोई औरत हमें बताती है कि पंजाबी में जो क्या कहते हैं हमारे साथ रुक गए मेंस वगैरह, तो हम कहते हैं ये उसमें आ गई है प्रेगनेंसी, हम कहते हैं चेकअप कराएं। फिर उसके बाद ये जब मस्ट हो जाता है कि ये इसका ये है, फिर हम उसके पास बार बार विजिट के लिए इसको लेके जाते हैं अपने BHO के लिए। इनके पहले इसको मोटिवेशन करते हैं उसको जीन को कि आपने अब जाना अपने यानी सारा उसको चेकअप कराने के लिए लेके जाते हैं अपने। फिर उनकी दीवारों पे हम उनकी दीवारों पे ना 1034 लिख देती कि अल्लाह ना करे कोई इमरजेंसी आपके साथ हो सकती है, तो आप इस वैन को एम्बुलेंस को फोन करना है और मुझे भी कॉल करनी है और हमारे BHO में आपने आ जाना, ठीक है। उसके बाद उसकी जो फोलिक एसिड वगैरह उसका ध्यान रखना, उसके टीकों का ध्यान रखना, ये हमारी जिम्मेदारी भी होती है।
So, I'm thankful to Razia, the lady health worker who has joined. I will be interpreting the response. He has shared when they come in contact with the lady, any pregnant women for the first time. Firstly, they counsel them, they do their routine antenatal checkup, and then also assist them in going to the nearby health facility so that they are also checked by a trained SPA in the facility, whereas they also ensure that they conduct the regular visits at the facility. Accordingly, they also counsel family members as well as the pregnant lady regarding the ambulance service, and also guide them in case of any danger signs or any complication. If they see, they may directly reach out to the helpline number, that is 1034, and get in touch with the ambulance service for immediate transportation. During this process, they also share concrete information, awareness messages, as well as brochures with them, and even sometimes write numbers on in the telephonic directory, as well as do some kind of wall markings as well. In case there is any leading question, I may also interpret that for.
Thank you, Saida and Dr. Yahya, for responding to this first question. So we'll move on to the next question, which is being asked for from Mr. Bilal Ahmed, District Transport Officer among our panelists. What is the average travel time from a woman's home to the health facility? Over to you, Bilal.
Hey, Assalamu alaikum, ma'am. It's time 20 to 25 minutes. Patients reach at the required nominated facility, which was nominated by CRC, Call Response Center.
Thank you, Bilal. So I think I can take another question, which is directed to you. Have you ever experienced technical issues with the GPS not functioning correctly? And if so, what do you do in this situation?
Yes, ma'am, we face these issues, specifically in remote areas. GPS sometimes malfunction and operate not accurately. But with the call response center, we are connect to our drivers. Just every person was connected, like LHV, the center staff, and all the specifically jo DTO, district transport officer, uh, 24 hours they are in touch with their drivers. So if a CRC not is unable to reach them on GPS, we make a call and confirm the location. Uh, this will only take 1 or 2 minutes to confirm the location if there are some GPS issues.
And just a supplementary question that just out of a rough estimation, how much is the proportion of such instances when you have had such an issue? So like out of 10 or 100 cases, how many would have some issues with the GPS or CRC?
Ma'am, approximate 4 to 5%.
Great. Thank you so much, Bilal. The next question, we will be requesting Ms. Kenza Faisal, who is the beneficiary among the panelists, to kindly respond. What could have made your transportation experience better? So what would you recommend to have in this transportation system to have a much better experience by pregnant women? Over to you. I think Naeem Saab, Dr. Naeem, you will be interpreting. Dr. Naeem, please unmute. Dr. Naeem, unmute.
We are using the same mic and we are at the same place. So I'll just translate the question for her. So ये आपसे पूछ रहे हैं कि आपका जो ये एक्सपीरियंस है सारा कि मतलब एम्बुलेंस आई आपको लेके गई अस्पताल तक आप पहुंचे वहां सर्विस थी तो इसको मजीद बेहतर कैसे किया जा सकता है एम्बुलेंस के एक्सपीरियंस को
अस्सलाम वालेकुम मेरा नाम किंजा फैसल है अस्सलाम वालेकुम मेरा नाम किंजा फैसल है मुझे जैसे ही दर्दें लगी लेकिन मुझे तो देर से नहीं ट्रांसपोर्ट मिली जैसे ही मेरे मियाँ ने फ़ोन किया तो ट्रांसपोर्ट तकरीबन 10 से 15 मिनट के अंदर अंदर आ गई थी और 25 मिनट के अंदर अंदर उन्होंने मुझे हेल्थ सेंटर पहुंचा दिया था तो मेरे ख्याल से तो ये ठीक है इसमें कोई देरी नहीं है अगर कोई मुश्किल उनको ना पेश आए रास्ते में या कोई हादसाती तौर पे वरना तो ये मेरा तो पहला एक्सपीरियंस बहुत अच्छा रहा मुझे तो टाइम पर ही जो है वो एम्बुलेंस ने जो है वो लिया और जो हेल्थ सेंटर था वहां पहुंचा दिया और वहां पे भी मेरे साथ बहुत अच्छा जो है वो किया गया ट्रीट
So, a supplementary question to this that do you think something different could have helped you during the travel from home to the facility, or whatever you experienced in that travel was perfectly to your expectations? Dr. Naeem, we need you to use the mic. Dr. Naeem.
मेरे ख्याल में तो इनकी अगर तादाद बढ़ा दी जाए तो ज़्यादा बेहतर है क्योंकि तादाद बढ़ाने से ये है कि आसानी होगी जो एक एम्बुलेंस वो 10-15 मिनट में आती है वो ज़्यादा जो है वो घरों पे ज़्यादा तवज्जो हो जाएगी उसकी बढ़ाने से ही ठीक है बाकी तो इनकी सर्विस बहुत अच्छी
Great. Thank you. Thank you for your response. Maybe if someone can interpret this.
Yeah, so she is a beneficiary and this was her first experience and when the labor pains had started her husband called the ambulance and within 10 to 15 minutes of the call the ambulance arrived at her doorstep and within 25 minutes she had reached the health center. She is saying that it is a very good service and there is no issue in her experience and it was her feedback is very good and that she was very treated very well at the health facility as well. About one thing which he is suggesting which could be improved is that the number of ambulances could be increased so that the response time can be even better. Other than that, the service is excellent.
Thank you, Dr. Naeem. Now there are a couple of more questions for the transport officer, Bilal. So what about issues with accessing roads such as during floods? Does the ambulance service still operate?
Yes, ma'am. We still operate in those conditions. Lastly, we operate off road also. If there are no road, we still went there to pick up the patient and reach them.
And the ambulance is able to travel off-road.
Yes, ma'am.
Thank you.
We have specifically, ma'am, 47 vehicles for unreachable areas, mountain areas like Attak, Rajanpur, Rawalpindi.
Okay.
4x4 vehicles, even desert areas like Muzaffargarh, Chang, 18 Hazari, like that.
So it is customized. The
Yes, ma'am.
response is, yeah, according to the area.
Requirement, ma'am.
Great. The next question again to you is the call center receives 5,000 calls a day. How are these calls divided among the call agents?
Ma'am.
Yes, Assalamu alaikum. This is Mansoor from Call Response Center,
Ji,
Lahore.
over to you. Sorry, Mansoor Saab.
Thank you.
This question is for you.
Thank you, ma'am. Thank you for your question, ma'am. Actually, we are providing service around the clock, and mostly call we are receiving at the morning time. So, looking at for the call flux, we plan agents in more agents in morning time, and then in evening, and less agents in night time, ma'am.
But in our experience, more often the emergency for a delivery is also a more frequent event in the evenings and in the nights. So, has it happened any time that you had less responders?
Sometimes it happens, ma'am, but for that we have backup agents already available, so we deputed them on calls. In this case, ma'am.
Thank you. Thank you, Mansoor, for the very relevant response to this question.
Thank you.
I'd like to pose the next question to Ms. Saida, lady health worker. Who will escort and assist the woman in the ambulance if she is experiencing an emergency? So, Dr. Yahya, if you can interpret.
Yes, sure. इसमें ये पूछते हैं कि जब भी कोई खातून आती है और उसको एम्बुलेंस में जा रहे होते हैं तो आप लोग उसको साथ भी जाना पड़ जाता है वहां पे, ठीक है ना, और उनको असिस्ट करने के लिए। तो क्या इस मराइल के अंदर जब उनको ट्रांसपोर्ट किया जा रहा होता है किसी हायर फैसिलिटी पे फॉर एज अ रेफरल, या जब कम्युनिटी से वो आ रहे होते हैं, तो उसमें कोई मुश्किलात पेश आ जाती हैं? आपके एक्सपीरियंस में क्या इस तरह की कोई इमरजेंसी सिचुएशंस होती हैं, तो उससे कैसे आप डील करते हैं?
We cannot hear the response.
Assalamu alaikum. My name is Muzammil Amana. I work in a basic health unit, Ali Razabad, as a LHV. Their parents, they attend.
Can you please speak a bit louder?
जी, जब हम लेके चलते हैं मरीज को अपने साथ, अक्सर मरीज हमें फोन करते हैं, हम उनके साथ जाते हैं BHO तक, ठीक है। अक्सर एक तो पेशेंट का ऐसा हुआ कि रास्ते में ब्लीडिंग शुरू हो गई, तो जब तक हम वहां गए तो मैडम ने फौरन से हमें जना रेफर कर दिया कि वो बहुत कॉम्प्लिकेट हो चुका था। तो एक का BP शूट किया, मगर वो मसलन ना, उसको जाते हुए उन्होंने एक ट्रिप दी, मगर वो बिल्कुल सही नॉर्मल डिलीवरी, मगर जो था ना जिसका ब्लीडिंग शुरू हुई वो हम उसको जना ले गए थे फौरन से फौरन। बस ये, मगर ये शुक्र था कि हमारे पास 10:34 थी, बहुत सहूलत थी हमारे पास। अगर उस वक्त हम किसी गाड़ी का अरेंज करते तो मैं उसके लिए हमें कोई बड़ा हादसा देखना पड़ता, मगर शुक्र अल्लाह का कोई 10:34 वाला हमें आगे भी लेके गया।
So the lady health worker, she has shared her experience. On several occasions, they have witnessed cases in which there were incidents of bleeding, excessive bleeding during transportation that has occurred, or the patient were known hypertensive. And in that case, even they had informed the facility staff before time for their readiness, including when the patient was received at a 24/7 primary healthcare facility. So they also managed to do a higher level referral that was more done in a timely manner, and the concerned facility staff was also informed. And as far as the bleeding was concerned, so they did assist the patient in during while the transportation. So this is the experience regarding the lady health worker who have assisted and were accompanying a pregnant woman in the ambulance.
Thank you. The last but not the least question is being requested from Dr. Shahzad. Do you think this service will be replicated in other provinces in Pakistan? What do you, Dr. Shahzad?
Okay, thank you. Regarding its replication in other parts of the country, yes, it is being considered as our department has been approached from many provinces like KPK and Balochistan, that how they wanted to know how it works, and it has been they were very willing to do that and to replicate it in their own areas, depending upon the terrain and the budget and its function. Especially, they were interested how the operations are working, because uh, we have hired or managed a third party in its operations, which have been very efficient. So, especially this part, they were interested, and it has been given many presentations that how they can replicate and reduce their burden of maternal mortality.
Thank you, Dr. Shahzad. This is very encouraging to know that provinces have already expressed their interest and are keen to learn. So we are all done with the questions that we had in the list. I'll just like to thank all the panelists for being with us today and for responding to all these questions while sharing your experiences from the field, and also to appreciate this great learning trajectory from the Government of Punjab that has reached to a very important stage now, that you are able to support other provinces in replicating the model in other areas of the country. This is indeed a very important experience and a very relevant and need-based model that addresses a key challenge, a key issue that underscores so many of maternal and perinatal health outcomes in Pakistan. With this, I'll hand over back to Caitlin to continue with the rest of the agenda. Thank you so much, everyone.
And thank you, Dr. Kutsia. Yes, for our attendees, please feel free to continue asking questions. You're welcome to submit those in the chat box, in the Q&A, or if you'd like to raise your hand, you can voice your question that way as well. We did have a question come in regarding how the initiative has helped in scaling up the approach in Punjab and the political commitment. I'm not sure if our folks from the Punjab government, Dr. Shahzad, if you'd like to speak to that.
Okay. As far as I have understood, what they want to know that it's sustainability. Yes, it has been started at a small scale. Later on, it expanded, and now it has been regularized in the in the recurrent budget, which is being allocated every year for this special initiative.
Perfect. Thank you so
Okay.
much. Oh,
All right. I want to add add to that the other part of the question. Yes. Despite many governments have been changed and they have their concerns about the ex-government, but after due deliberation and looking and probing everything, it has been finalized that it is more efficient and has been adopted and approved by the by the political will and commitment, and it is supported and going to continue, hopefully. Yes.
thank you, Dr. Shahzad. Great to hear that this initiative is sustainable, and that you will continue to move forward with providing this service to pregnant women and sick children in the province. So thank you so much for that. And do we have any additional questions from our attendees? Okay, perfect. Well, yeah, huge thanks to you, Dr. Kutsia, and all of our implementers that showed up today. What an honor to hear from all of you on the ground that are not only operating but also benefiting from this service. I myself particularly liked hearing about the 4x4 vehicles for homes and areas with roads that are difficult to access. And yeah, also very important that you shared the process for women that are experiencing complications such as excessive bleeding, as I was curious about this piece myself. I'm so glad that we were able to gain a unique glimpse into this system. And yes, as I mentioned earlier, learning from others and sharing strategies right now that can be adapted to other contexts is key during these challenging times. So I hope that you were all able to do just that today. As we come to an end, I would like to introduce Dr. Karima Gobzori, the Regional Advisor for Sexual and Reproductive Health and Research within the Department of Healthier Populations from the World Health Organization's Eastern Mediterranean Regional Office. Dr. Karima will be delivering closing remarks. And thank you for joining us, Dr. Karima. Over to you.
Thank you so much, Caitlin, and thank you all colleagues who are joining us in this meeting. It is my pleasure, of course, to add some words to conclude the session. But before concluding the session, I would like just to congratulate Pakistan team, all the Pakistani government, the Punjab team, and then each member of Punjab, because I know how it is demanding, and then it's not an easy step to go for, to be able to ensure a good coverage and then to respond to pregnancy care and then also the assisted delivery care in Pakistan, namely in Punjab. So we are very proud to have this really good, I would say, intervention, it was also well documented, thanks to our colleagues from WHO headquarters and then also all the team that we have in Pakistan. I will start with the positive note, because whatever we do, at the end, always we are targeting women, and then we want to ensure, that we are responding to their needs, and then especially when it comes to pregnancy and delivery and postpartum. Pakistan, we just published the maternal mortality estimates, and I think all of you know, we shared it officially. And then one of the positive things that also we want to share today is that Pakistan has reduced the overall maternal mortality ratio reduction by 65% between 2000 and 2023. So in 2000, you were 419 maternal deaths. per 100,000 live births. In 2023, you reach 155. So really, we have to congratulate you for all the efforts. I know a lot is being done through all the continuum of care when it comes to sexual reproductive maternal health. And I know you are working on different layers of the health system, starting at the community, starting also including primary health care, self-care, and then also hospital, different levels. This, I would say, good initiative. It is highly saluted from our side as a regional office, but also on behalf of all the regional office, because I know this is a very good start for improving not only the coverage, good quality of service, and being there for our women, and then also saving lives and avoiding preventable deaths, whether for maternal and newborn. Therefore, I think the way we documented it shows that there is a high commitment to scale up, to sustain, to institutionalize. Our role is to be always there to support you, to ensure all these steps, whether technically, but also we can also support it financially, and then we can also mobilize funds. Also, we would also seek your support to disseminate this beautiful experience, throughout other countries. We have countries, especially the humanitarian settings, they would be very interested in this, and then they have funds, but they just need to know how. So we will be seeking your support. Thank you to all the team, our country office, under the leadership of RWR, to you, Qudsiya, Ellen, and Saima, and to the beautiful Naeem, and then your team, and then all Punjab team. Yahya, one by one, please salute everyone, and congratulations. Bless you all. Thank you so much, Caitlin. I'll give it back to you. Thank you.
Thank you, Dr. Karima. Yes, for such a beautiful conclusion to such an interactive and engaging discussion today. Yes, I would like to thank everyone for joining us today. I believe we will be wrapping up now that we have completed our Q&A, but as I mentioned before, this recording will be available on the WHO HRP Comms YouTube channel. So feel free to share this with your colleagues, with your friends, and within your networks following the webinar. So thank you all so much for joining, and a happy belated World Health Day.
Thank you so much.
Thank you, Caitlin, and all.
Thank you.
Thank you, everyone.
Thank you, everyone, for a great webinar. Thank you.